When you're ready.
Do you want to control it, or do you want me to push the button?
You can do it. You want me to just hit you when I'm ready? Or do you want me to do it?
No,
Then you can do something else.
no. This is what I'm here to do.
Do they know what I'm talking about?
Yes.
Do now. They do now. Are we ready?
Yes.
Hey, everybody. It's so nice to see your faces again. So again, I'm Carolyn, and I'm the nurse educator with the AIDS Education and Training Center here in Morgantown. So Caitlin let me know that you all had expressed an interest in doing sexual histories in your practices. So that's what I put together today. And I really just put together a very basic sexual history. I know that there were people that were interested in LGBTQ and in adolescents and in trans persons. And if you all like this presentation today, then we can go further into each one of those particular populations, because there's so much to be said about each one. Okay, you sure you want me to do it? I can. I'd do it.
Okay.
I'm going to do my own controlling. So I do not have any disclosures for today. Oh, wait a minute. Uh-oh.
Just click it.
Just click the mouse.
Yeah.
All right. And these are the objectives for today. And again, very, very basic. I have a question. Do you all already do sexual histories? You can nod your head. You can, anything you want. You can cover your face if you're ashamed. Yay. All right. So you all might be able to help me a little bit then. So these are the objectives today. No. Yeah, you can. Oh, and then I have a thing at the end of the presentation. I'm going to offer to do something. All right, so why do we want to take a sexual history anyway? Why is it so important? Well, because if we're looking for STDs or STIs in particular, we can do early diagnosis, testing for HIV, and that helps to prevent any associated morbidities that go along with having an STD, whether they are short-term or long-term morbidities. Helps to answer patients' own questions about their sexual health. Do any of your patients ever ask you to talk about their sex life? Oh, somebody's going, other people are, yeah. Sometimes people are really reluctant to talk about their sex life, but the more that they know you and the longer they've been coming to see you, the much easier it becomes, because they build a level of trust with you all. And then in order to identify people who are high risk for unplanned pregnancies, and then also victims of sexual abuse as well. So those are a few reasons why, and here's a few more. So we can treat sexual dysfunction in patients. You know, sex is a wonderful part of just living day to day. And if you're a woman who is pre or post or perimenopausal and you're having a problem with lubrication, sex isn't very fun. But there are things that we can do to help her with that. Same way for men. If they have erectile dysfunctions, not only can they hear Bob Dole talk about it, but they can talk to you about it as well. And then what about doing primary and secondary prevention of HIV? Getting any information that will help us guide risk reductions for STDs. Hey, I see that guy in the back laughing, that young student. You're going to learn a lot today. And then to identify the anatomic sites that we want to screen for STDs. So if somebody comes in to your practice and has either presents with symptoms or tells you they have something going on, when you do STD screenings, where do you usually go anatomically?
Genital.
Genital. Where else do you go?
Throat.
Yeah. Okay. Anywhere else? What about anal? Yeah. So those are the sites, all three of those sites we should be looking at when we're screening and testing for certain STDs, because there are so many different sex acts out there that people do. You know, a penis in the mouth, a penis in the anus, as well as a vagina. So you're going to get an STD at all of those places. So that's why we screen at those particular sites. So look at STDs in the U.S. 2017. You can see there's been increases in chlamydia, gonorrhea, and syphilis since 2013. So these cases continue to rise. And these are cases of STD rates by sex. And if you look at men less than women, so women are getting more STDs between 2000 and 2017 than men. Why do you think that might be? You guys don't mind answering questions, do you? Why do you think more women than men might be getting STDs?
They're more likely to get screened, probably.
Hey, that's a good one. More likely to be screened. That's really good. If I had a prize here, I'd give it to you.
Oh, I like prizes.
I know. Hey, if you let me come and do a program, you can get all the prizes that you want. So why else? And that really was a good one. More women than men. I wonder if they're taking into account people who work in the sex trade. And we think mostly it's women working in the sex trade. So all kinds of reasons why we might be seeing more in women. Chlamydia, and this is by region, seeing most of these cases in the southern part of the United States between 2008 and 2017. And these statistics are from the CDC, and this is the most recent data that they have. And gonorrhea, again, a rise from 1996 to 2016 by region, again in the South, and then primary and secondary syphilis cases as well. What are you guys seeing in your practice regarding STDs?
Chlamydia.
Mostly chlamydia?
Chlamydia and Hep C.
Yeah. Oh, Hep C, absolutely. Are you seeing that in heterosexual situations or mostly MSM?
Yeah, it's all been all of the suspected routes of transmission are heterosexual. I've not had MSM as a risk factor for acquisition, but I always kind of suspect that maybe they have other risk factors as well too. It's usually not just that, but that's typically the one that's reported.
I see. Among the heterosexual cases. Okay. That's interesting because it was really first identified among MSMs, hepatitis C. So
I suspect there are people that shot up drugs sometime a long time ago and just don't disclose that.
Yeah, because they're embarrassed or they're afraid of your reaction or what have you.
Yeah, I would kind of agree with that, with the chlamydia and Hep C. I guess I've had one Hep C case that was MSM. The others have all been heterosexual people.
Really? That's very interesting.
Yeah, but it's probably really mostly transmission through drug use rather than through
Yeah,
sex.
probably so. But then that's what gets reported as whatever they're reporting as their risk is going to get reported as heterosexual rather than IVDU related.
But the reality is that heterosexual transmission of Hep C is pretty uncommon. So this will just maybe inaccurately skew those data.
That's exactly my feeling. That's what's happened in the cases that I have. I suspect it's not that.
Yeah, we're not getting the whole story.
Yeah. You know what? Maybe one of these times you will. So we don't ask. We do know that primary care providers and many other specialties as well do not ask about people's sex, drugs, and rock and roll lives. Less than 40% obtain a sexual history, and then we ask even less on successive visits. And I think a lot of people, it could be related to being uncomfortable regarding delving into people's personal problems. So they think, well, I did it once, I don't ever have to do it again. Well, that's not true, because our sex lives change over time. So it would be us and the patient to ask at every single visit about what's going on in their sex life. No, I'm not doing very good with this, am I? Over here. So don't ask, don't know, don't tell. So around 64% of women in this age group said it's up to you guys, or us, as healthcare professionals, to start that talk about STDs rather than the patients themselves. This is a very poor statistic. Only 10% say that we raise the subject of STDs other than HIV. And only 3% of women brought up STDs themselves. So here's a reason why we can take this challenge on ourselves as healthcare professionals. So how come we're not doing sexual histories? I think this is probably the biggest one. Uneasiness of clinicians regarding talking about subjects that are really kind of in your business. We delve a lot into exactly what's going on in the bedroom or the back seat of the car. A lack of understanding regarding how sexual health is related to our overall health. The lack of time, fear of offending the patient. And this actually, somebody said this to me, to Jeanette and I during one of our trainings, and this has been a couple of years ago, that they will not talk to their patients because they don't want to offend them, and they are afraid that the patient will fire them. We're talking about sex, drugs, and rock and roll. And then what kind of curriculum are we seeing in medical and nursing schools, dental, regarding sexual history taking? Not a whole lot. I don't know if that's changing, but I would hope that it would be changing. So some principles regarding taking a comprehensive sexual history, and I put these in the order that I thought that they went together in the best way, but as I was looking at them, they might be a little out of whack. So really take the order of the slides with a grain of salt, because there are some things that you may want to think about first rather than going down what I have listed for you. It's all and how comfortable you feel and the way and your comfort level with your patients. So we want to ensure confidentiality. Sometimes that's pretty difficult, especially if we're in an emergency room setting. You want to be professional, be non-judgmental and open-minded. I have to tell you, everybody has their own personal values and morals that they live by. But we need to learn as healthcare providers to leave those at the door when we go in to see our patients, because if we behave in any judgmental way, our patients are going to shut down and you won't elicit to any responses whatsoever. So just leave your own stuff at the door. You know, if you don't like the fact that people sell their bodies for sex, that's okay, but you don't want to relate that to the patients when you actually go into the exam room. Look and recognize nonverbal cues from patients, and only ask questions that are appropriate for each time with each patient. And then regarding communication skills and I know that you guys know this, but when you greet a patient, you want your initial greeting to be open and warm and welcoming, and that doesn't always happen, especially to those in the LGBTQ community, and I will have to say especially those who are trans persons do not always get that warm welcome from their healthcare provider. That's why they seek healthcare from specialized trans providers, because they know they're not going to be judged. You want to maintain eye contact, and then you want to ask for their permission to talk about things that might be kind of sensitive. Did you guys ever talk to your children about their own sexual health?
Yes.
Kids? Do you have parents? The more that you do it and the younger that you start, the easier it becomes. Talking about sex becomes like talking about a paper clip. It is so ordinary and mundane. But it's just getting those conversations started with patients that sometimes is the difficult thing, and the kids as well. You want to listen attentively, be respectful, and be sensitive to cultural issues, and also be sensitive to gender identity and sexual orientation as well. Anybody see any trans patients in your practice
I don't think so.
that you know of? Yeah, you do, Dr. Peters. If you're not sure about your patient's gender identity or even their sexual orientation, you can ask them what pronouns they prefer. So I identify as a straight female, and my pronouns are she, her, and hers. People, if you ask, people will tell you what their pronouns are. So that's kind of helpful as well. Any questions so far? Any comments? No? All right. So this is really important, I think, as an educator. You want to start with questions that are less threatening. Imagine yourself going into your own provider's office for a well visit. And they greet you, and they sit down, and they say, all right, have you ever injected any drugs? Are you having sex with men, women, or both? Those would throw me off if that was something that was started right away. So you want to start with questions that are less threatening and do something that you do every time. Maybe start out by just reviewing their medication list, or review why they're in there today. See if you can tie it in at all to beginning that conversation about their sexual and drug using history. So doing those easy things first that we do all the time, talking about their drugs, why they're here, how's the family, then you can start asking the harder questions about smoking. You know, asking people about smoking is asking about their health and their kind of risks for certain disease processes, as well as alcohol use. And then you can talk about drug use. You know, do you ever use, or do you have friends that use, acquaintances? So you see this, and then you can get down to, have you ever injected any kind of drugs? The first time that you do this, you may get nothing. The patient may say, I don't want to talk about this. But the next time they come in, they'll be more than likely, because they know that that's what's going to be expected of them anyway. So you want to tell the patient why this is so very important, that you want to talk about their sex life and potentially ask questions about drug use. And these are questions in here. I don't have them in the little, what do you call those things? Quotes. But I'm going to ask you, and this is actually, you can steal this from me. I'm going to ask personal questions, and I'm asking all of my patients to help me provide you with the best possible care. Why would you want to tell each and every patient that you were asking all of your patients the same question. You want to know why? Because people talk. Patients talk to each other. Give that example of something last week. Jeanette's going to tell.
About
What
you
was
and
that? Yeah.
I mean, it's not related to sexual stuff.
It's not related to sex
My
stuff, but this
physician-
is about our physician that we share as a primary care provider.
She wanted me to do the colon things where, you know, you do the 3 things of colon, or 3 minutes of bowel, stool, send it in, mail it in. I don't know, it got lost in the mail, so she told me I had to repeat it. I'm like, yeah, I've had it here, I'm not really going to repeat it. She goes, oh, all my patients have to do this. And I said, well, I know a patient that didn't have to do it. And she goes, well, she must not have it under her insurance. I said, the same insurance as mine. And she goes, well, her provider just must not be aware of it. And I said, it's the same provider I go to, you. And so, you know, she was not doing it for all of us, and why she chose me, I'm not sure. But then they said, well, we'll have to review all our charts and then take care of that. So Carolyn might shoot me the next time she goes back.
So we both have the same provider, and this actually happens in the HIV clinic as well. I mean, not in the clinic, but between patients. They talk to each other about what their providers are doing or not doing for them. So that's why it's really important that you, when you start this process of really doing sexual histories, that you make sure you tell your patients that you're asking everyone the same questions so that you can provide them with the best possible care. I want to ask direct questions about specific behaviors. So when was the last time you, and then you can fill that in for yourself. How often? Have you ever exchanged sex for these things? Money, drugs, a place to sleep? People, and it's mostly women, it's not all women, will exchange sex for a variety of things. It could be for their next dose of methamphetamine. It could be for a meal from McDonald's for the kids. It could be for a pack of diapers. So we will exchange sex for anything. Uh-oh. Wrong one. And then using exploratory questions as well. You can say, do you or your family or do your family or friends ever use drugs? How easy is it to get them where you live? And if you normalize behaviors, you're going to get much better information from your patients. So by helping to normalize a behavior, and that includes shooting up. Some of my other patients inject. If they don't understand what inject means, you can say shoot up or whatever the verbiage is that they use. Is this something that you do as well? When you ask questions like this, you are being so very non-judgmental. You're just being matter of fact. I'm asking you this. I hope you'll tell me so we can provide you with some really good care. Another thing, sometimes people have anal sex. Well, there are people that do not understand what the word anal means. So again, you may need to use slang or some other verbiage. So just asking questions that are really kind of forthright, I think increases respect from patient to provider. So we have 5 P's of sexual health. Number 1 is partners. And again, these are just questions I've listed that you can ask. Do you have sex with men, women, or both? How many partners have you had sex with in the last 2 months? In the past 12 months? Why would you want to know how many in the last 2 months and in the last 1 year? Why would you ask that kind of twice? Any thoughts? Oh, go ahead. Somebody wanted to say something. Okay. Nobody?
I was just thinking it could be if their situation has changed. you know, if suddenly they've become homeless or something and they're having to have sex, as you said, exchange sex for a place to sleep or whatever.
Yeah, absolutely. Yep. People don't always keep their same sex partner over a week, over a month, over 2 months, over 6 months, over years. And try to think about that too when you're seeing pregnant women, is that they don't always keep that original partner who they got pregnant with. Sometimes they will change partners during the pregnancy. So it would behoove you to ask your pregnant women about that as well, because if she has changed partners during her pregnancy and you had offered HIV testing in that first trimester and it was negative, you want to offer her testing again in the third trimester, and you may identify a new case of HIV. So if she's identified even as late as the third trimester, we can still have an impact on mother-to-child transmission, even that late into the game. Okay, and I'm almost done. And then here's another question. And then practices, again, these are just questions that you can answer. What kind of sex have you had? Have you had vaginal sex, anal sex, oral sex? Do you use a condom? And a lot of people do and a lot of people don't. And you may want to find out why people don't use condoms. Some, it could be situational. Others, it can be fear of abuse from a male partner regarding the use of condoms. Regarding another one is prevention of pregnancy. How do you protect yourself against STDs, including HIV, and then the past history of an STI. So those are the 5 Ps. And then concluding the sexual history, you want to thank them. A thank you goes a very long way for everyone. Inquire about any concerns they might have. Do they have any other questions now that you've opened the Pandora's box? Do they have any other questions about their sexual health? Talk about any high-risk practices and then make referrals or develop a plan for any testing. So when should we ask? Every single time. Excuse me. Patients come in for a visit. Anybody like role play?
I think you're gonna have time.
I'm not doing it.
John doesn't
role play. John's sitting over here going, no, I don't like it. I don't like it. Role play is a wonderful tool to practice taking a sexual history without getting all flabbergasted and weird. And that's something that I or Jeanette would be willing to come and do just to help you practice a little bit.
I could demonstrate the flabbergasted weird.
Go ahead.
No, I'm just kidding. I'm becoming my funny guy.
Backed up against the wall, the corner.
I usually back up before I ask the question.
Oh, you need
Terrible.
to
Face is red.
But anyway, that's something I think is a whole heck of a lot of fun. And if you knew me, you would know I like to have fun, especially when I'm teaching. So that's always a possibility. We'll come where you are. And then I just want to thank Jeanette because I stole her slides. And then the Southeast AIDS Education because I stole some of their slides as well. So if you guys have questions, if not, then you can talk to John.
But not about sex.
Well,
But not about sex, by golly.
just give me some numbers. I'll look at numbers.
I just have a couple comments. This is Kaylee. Just kind of my approach to, because it is uncomfortable. And I remember when I first started doing this, Jeanette and Carolyn, really, this lecture really helps a lot too. And it does take practice. So start with somebody that you might know pretty well, because we all have those patients that we just naturally feel more comfortable with. And I usually just say, you know, we as providers don't really do a great job at talking about sex and talking about sexual health. So I'm really trying to do a better job at it. Do you mind if I ask you questions? And then it kind of, you can kind of make it a little bit less informal with somebody that you might already feel comfortable with. I make a big point not to use the word monogamy, because monogamy means different things to everybody. So I've had patients tell me they're monogamous, and then I ask how many partners in the last week, and they'll say 7, and they meant like within the last couple days, you know? So, I mean, it really just, that's a variable term. Or they might be monogamous, but their partner's not. So, I mean, just with verbiage, I know that's pretty specific, but I tend to say, you know, relationships and sex come in all different shapes and sizes. So that way it doesn't really seem as like you're going into the conversation being judgmental. But it does take some time and persistence. I've had patients I've followed with for a long time, and I seem to ask them, and then eventually they'll come around and say, I thought about what you said last visit, and I'm willing to share some more information with you this time. And that feels good too. So practice. It gets easier over time.
Points.
It does.
Yeah.
Thanks, guys, so much.
Thank you so much.
Appreciate that.
And guys, if you have any follow-up questions, Jen, you're welcome to ask one now too. I see you unmuted yourself, but you guys can always email me and I'll forward those.
Well, just for a future topic, I work a lot with adolescents, and I basically try to do, you know, follow those principles you outlined, but I do think that it's a special population. So, and so anyway, it might be interesting to have a separate talk about adolescent.
And actually, that was my plan, because trying to cram in just a basic sex talk, and then cram in how do I talk to lesbians, how do I talk to gay men and transgender and adolescents, and then the elderly, all will take a separate didactic. And if that's something that you guys want, well, I mean, you just said you did, Jen.
Yeah.
Do an adolescent one, because they are buggers. They are so hard to talk to.
Well, they tell you everything.
They clam up, and they are slouchy and sulky, and, you know. So we'll do one about that, and then we can do trans people, because, you know, trans persons are pretty common in West Virginia.
Mm-hmm.
And they're a very special and wonderful group. So we'll just, as time goes on, and, you know, if that's what you guys want, that's what we'll do. Okay.
Excellent.
Okay.
Thank you, Carolyn.
You're welcome.
Thank you, everybody. Greg, if you're ready, I'm going to share your case.
Yeah, let's move. Do this.
All right. Let's see.
Hold on. Can you guys seem to be struggling? Give me a second.
I'll be honest, when the during the didactic, it was a really good didactic, but when you asked if anybody liked role play, I was afraid we were about to go in a very different direction of this conversation. I was afraid, oh man, we're not going to show hands. That's going to be bad. Like I was nervous.
You're safe, Greg, because John is here.
I know. Thank God. It was.
Right, you guys are too funny. Just think if we all got together and go to the park.
Oh man.
And we would do this role play, and how much fun it would be. You know, it's nice outside, and everybody would learn so much, right?
Oh my. It's so yes, this patient is a guy that, I'll be honest, I don't know very well. I met him once, and he's coming back in. It actually doesn't know that he has chronic hepatitis C. He knows that he's screened positive, but doesn't know a lot. But I wanted to go ahead and present him because I had a couple of questions about management. And I think he illustrates a point that we touched on, I guess, kind of during the didactic, and that he has no real certain mode of transmission. He's a 54-year-old male with Medicaid, whose only identifiable risk factor may be heterosexual contact, and he does have a non-professional tattoo. He does not admit to any IV drug use ever in life. We diagnosed him a couple of weeks ago. His genotype is 1A. Clinically, I would say that he paints a picture of somebody with cirrhosis just based on his labs, but does not carry this diagnosis formally yet. He was seen through our walk-in clinic initially for some high blood pressure, just not feeling particularly well. Had some bilateral lower extremities. Bilateral lower extremity swelling. Sorry, and so he started on hydrochlorothiazide for both of those things by the walk-in clinic provider, and then kind of sent to me. He's never been vaccinated against anything in his adult life, and he has never had a PCP until now. He is an alcoholic, although doesn't really identify as such. He thinks that he just drinks a little bit too much every day, but as he says, only beer. His PHQ score is 0 on intake, but then when you kind of delve into it a little bit more and talk with him about exactly why it is that he's drinking and, you know, what is it that he's maybe sort of self-medicating and that sort of thing, it looks like he has some depression that's never been addressed before, and probably, well, certainly some depression that's being caused by his alcohol use. He admits to drinking, you know, somewhere between 6 and 8 beers every day. He smokes, currently smokes about half a pack per day, and we're planning on screening him for lung cancer and a AAA. So here are his labs. His labs are interesting, at least to begin with, because his platelets are low. He has transaminitis, which is consistent with alcoholism, and then also with his hepatitis C. He has, his INR is elevated, kind of further suggesting that this guy's got quite a bit of liver pathology. Total protein is low. His MCV is elevated, probably just from the alcohol. His iron studies are present here. Yeah, his iron was fine, but his TIBC was actually low. I kind of had a question about that. Maybe we'll delve into in just a bit. AFP, 8, HIV, Hep B, all that good stuff was normal. He's an F4. But has never had any history of decompensation and doesn't really have any evidence of decompensation. Our plan is to get a right upper quadrant ultrasound, or I'm going to talk to him about getting a right upper quadrant ultrasound as well as an echocardiogram. We'll take a look at his aorta while we're doing all of those things to make sure that he doesn't have any other signs of failure and that it's just his liver. Let's see, what did I write here? Oh yeah, I'm going to talk to him a lot about why drinking is bad and why it's especially bad for him, and see if we can't get him in some sort of a plan to decrease and ultimately cease consumption of alcohol. Same is true of tobacco, by the way. We talked about the ultrasound. I failed to order actually his vitamin D, but I'm certain it's low. Iron is low, and the the iron is normal and the TIBC is low. And so I kind of wondered, is that somebody, even though he doesn't really have an elevated iron, is that somebody that you really have to think about hemochromatosis for if they have just an isolated low TIBC? I'm just not really very familiar with that. I've found one patient with hemochromatosis who also had hepatitis C, but their iron level, their just serum iron was elevated. So that's kind of him in a nutshell. That's kind of a quick rundown of him. He's an interesting guy. He's never had a primary care doctor before. I think mostly because he's scared of having a doctor. I actually spared him sexual history questions the first time I met him for that reason. I didn't want to scare him off, but we'll actually delve into that the next time I see him, which is next week. So, but yeah, so that's him in a nutshell.
Thank you, Dr. Peters. I wanted to ask all of you guys your first impressions, thoughts, comments, questions. All right. Dr. Feinberg, Dr. Gilchrist.
Yeah, this is a fascinating and difficult patient, because he's 54, hasn't had a doctor, been drinking and smoking for a long time, probably didn't want to be told that he shouldn't do those things. And when you have more than one risk factor for cirrhosis, that's really not good. So he's got 2 and maybe 3. I don't, be honest with you, I don't remember that much the pattern about iron and TIBC, but hemochromatosis is not uncommon. And, maybe John is more, and Kaylee are more up in this than I am, but it certainly wouldn't be if the pattern is right, wouldn't be a bad idea to get.
And my understanding is that you can have kind of people that are heterozygous for hemochromatosis, and they have like kind of partial penetrance, that sort of stuff. So they'll have some pathology if they're at risk without having to have 2.
No, actually, the most common is to be heterozygous.
Sure.
All uncommon, and he just has a lot of bad actors leaning on his liver. Which is really not good. I don't think you're going to get any. He's a Medicaid patient, right? Well, actually, he's not old enough to be Medicare. He's Medicaid. You're not going to have any trouble getting drugs for him. Since he's not had much history of a patient, I think one of the other things to factor into this guy is that he's going to have to take this medication.
Yeah, his compliance is yet to be determined, really, as to whether or not he's ready to be compliant about anything, let alone this. And so we've got a lot to work on with him, and
he's got a lot of bad labs. He's got a lower limit of normal total white count. He's got a low ANC. He's anemic. I guess the issue is, he probably really also needs to be screened for other things, but the issue is, how with it is he? Would he even recognize blood in his stool? Depends on how much of the time he's really sober. Sometimes, what did they teach us in medical school? Divide the sex by 10 and multiply the alcohol by 10, or some sort of figure like that. So, only 6 beers a day is probably not quite there. I mean, there are, of course, medications for, blocking the release you get from alcohol. I mean, that's another thing to raise with him, right?
We actually talked about naltrexone, like giving him, talking about pills, that sort of thing. Just as I was explaining, he seems, the one time by seems, but he seemed interested in really exploring that and cutting back on the drinking. I told him between now, the time I saw him and doing all the labs and then coming back in to discuss those things, what I wanted him to do was to try to cut back gradually on his own and just see how much success he can have. That would just with trying to gauge, is this guy, I wasn't able to cut back at all, or, well, I'm down to 2 a day and it's really hard for me to get rid of those 2. It just paints a different sort of picture with somebody, at least as I'm trying to gauge their readiness for recovery or to really start taking good care of themselves.
I'm totally with you. I think that was an absolutely reasonable thing to do, and it'll gauge whether he really, got into this and made a commitment. I'm just really worried about his liver because he's really quite on the verge of decomposition, right? His albumin is 2.2. He's not a edematous though, huh?
He had the swelling, so not globally, I would say. So it's, he's got some swelling in his lower extremities, although when I saw him, most of that was gone just with the hydrochlorothiazide. But again, I don't know what, I don't yet have I don't know enough about this guy really to have a good appreciation for what sort of a picture he's going to paint.
Because I think his labs look really marginal. John's shaking his head. And I think this is a guy that could tip into being, having decompensated cirrhosis not that long from now. And he's really got to stop drinking. Really has to stop drinking. He has to get rid of his hep C. He really has to stop drinking. We may not know the whole story about how he got his hep C. And maybe it's this non-professional tattoo. But we
talked about it. It was a good story too. But he'll be he'll be interesting to see. I guess the other question that I would have is, I know patients that have cirrhosis with a history of decompensation need to be treated in conjunction with transplant services, transplant center, and that sort of thing. In a patient without that, a patient such as this, if he's able to stop drinking, if he's able to kind of clean this up, and if we're able to see some improvement as far as that goes, is that necessary, or would you still do that and get somebody?
So really, the step that you take first is to co-manage a patient who decompensates with a hepatologist or a GI doc who spends a lot of time dealing with liver disease. I mean, there is no the nearest transplant centers are Louisville and Pittsburgh, so that turns out to be not a very good thing for people in West Virginia. But just in terms of travel, if nothing else. But, he's not a transplant candidate unless he, A, cures his hep C, and B, stops drinking.
Right. Yeah, this is the guy. I mean, and that's why I really wanted to kind of talk about him. He's far and away, if I end up getting to treat this guy, he will be the sickest patient I've treated with hepatitis C. So I just don't want to do something that then decompensates. You know what I mean? I don't want to be in a situation where I'm doing him more harm than good by going after the hep C. I think our first plan is going to be not really to go after the hepatitis C. We're going to go after the drinking and see what we can do there, because I think that's his biggest opportunity for really longevity is that. So.
Right. And I think, along those lines, I mean, he probably should actually see somebody with these kinds of numbers. I don't think it's, I don't think it'd be a bad idea for him to see a GI and get scoped. He might have varices that haven't bled yet. I mean, I think getting a clearer sense of where his liver disease is, because the numbers look pretty awful. It looks so on the edge. And so, you never know what the moment of physiologic change is going to be. But I think it would be a really good idea. I mean, you should certainly get the ultrasound and stuff, but I would certainly also make sure that he doesn't have other things kind of waiting to happen. I don't know, you have other thoughts about the hemochromatosis stuff?
Not particularly hemochromatosis, Greg. I have a couple questions about labs, if you can pull up his labs. Definitely, you're right on the right direction with the alcohol. But his bilirubin at 6.8 on the sheet, is that real?
Oh, I didn't see that.
And then his sodium, that's right. Okay, what's his sodium level?
His sodium is normal, 137, but yeah, his Billy. I mean, the dude was orange. I mean, legitimately orange. It looked just did not look good. And I told him so. I said, listen, you have to understand, you're the yellowest patient I've seen today. Like, it's just I'm really, really concerned about this. And frankly, I think maybe that might even be why he came in, was the fact that he was swelling and understood that he was looking, he's looking bad. Who was with him that day? It was his sister. That's right. His girlfriend's daughter brought him in too, and she was pretty concerned about him as well.
It's hard with these patients because they usually don't come in until they're as sick as he was or is. But
this guy's sick.
When I go through and calculate his MELD NA, he's 19. And so once you get really, without being a hepatologist, I'm not comfortable with anything over like 9 or 10. But 19, typically over 15 is when they start referring out for transplant. Kind of the couple things too, and I don't know if you recall from when you saw him, but do you have any inclination as far as, was he encephalopathic at all, or insomnia or any asterixis?
No, I had no inclination. That was everything. He certainly didn't show any signs of encephalopathy.
It's hard sometimes. The GI team, because I always ask them, how are we really supposed to differentiate these people that are really this very subtle encephalopathy. And there's a test. I might do a didactic on decompensated cirrhosis, because I think there's a lot of stuff I've learned from the hepatology team here. But there's a test it's called an ANT1, Animal Naming Test 1. You basically take 60 seconds, pull out your cell phone, time them for 60 seconds, see how many animals they can name. And if it's above 15, then they're good. If it's anything lower than that, then it's a pretty good tool as far as.
So this is going to be a really dumb question then, but how would you, how would that be different than just being kind of drunk?
Well, and it's probably going to be a scale, but as far as doing some of these calculations, like Turcotte-Pugh score and everything, that's kind of just an in-office quick thing that can kind of help you gauge where he's at. As far as
when you asked me if he had any signs of encephalopathy, I don't know. Honestly, just to meet him and knowing his alcohol consumption history, I don't know that if he were a little off, if I would have thought, hey, maybe this guy's encephalopathic, or is like, nah, he's probably had 3 today so far. Like it's that kind of I don't know where I would draw the line.
I agree with you, because that's one of the hardest clinical exam findings, because it's really just very subjective. But so with his MELD being that high, I would definitely focus on his alcohol. I would worry that trying to treat his hep C at this point would decompensate him, and also by treating it may only improve his MELD slightly enough without cessation of alcohol that you're really going to actually put him at risk for getting lower on the transplant list. But one thing you could do, there's a new, she's a nurse practitioner, but the section chief with hepatology here at WV Medicine came from a transplant center. William Hudson's his name, but there's an NP that just started with him. She's got 10 years experience out at Baylor in transplant, and she's fairly new, so she has open slots. But she's somebody, I can give you her name, she's somebody I would go ahead and refer him on to co-manage, and hopefully with working on his alcohol and getting some of his cirrhosis medications adjusted, you hopefully can bring his MELD to a safe enough level you could treat him in the outpatient setting and save him a transplant. But at this point, I don't think transplant's even going to consider him because he's drinking. So that's an unfortunate thing with West Virginia, again, is we run into them not cover. They won't see our patients because we're in West Virginia. And so it's hard to get transplant referrals accepted. So you may have a safer bet trying to get them seen locally, as in Morgantown, and they can help facilitate that process when he's at that point. Yeah, he's a tough case.
Yeah, his glucose is 152.
Yeah.
I missed the bilirubin. I'm just noticing
Yeah.
his glucose is high too.
So he's and then with the ultrasound, you may want to get a full abdominal for ascites, so you can look at his spleen too.
Yeah, it's kind of interesting. His sugar, like Dr. Feinberg said, his glucose is elevated, but his A1C is 4.4. So it kind of puts his average at 80. So he's really interesting. There's a lot. I think there's a lot of moving pieces with him that kind of give a muddle or kind of a murky clinical picture of his lab.
But Greg, that A1C may not be real if he's got high red blood cell turnover. You're not getting an accurate picture of what his average really is. And it sounds like he may have that.
That's out of my.
Yeah, that's a good thought. I mean, he is certainly anemic.
That's really, I've never considered that before. That's really interesting.
Yeah, I've run into it in a couple people. Their A1Cs are artificially low because they have high turnover.
I always just hope my patients are artificially high. Like it's always kind of the way. That's the side of that. I'm just like, that's 16 can't be. That's not really 16. That's 6. The lab made a mistake. But wow, no, I've never thought about that. That makes a lot of sense though. If there was a reason for him to be.
Yeah. What's his MCV? Do you have it handy?
I do. Let's see here. It was high.
If he was losing blood and the alcohol, the low and the high influences may wind up with a normal MCV or something that looks normal.
It's 109, so it's elevated.
All right, so he's So his marrow was not doing very well under the circumstances, right? He has
No, and I thought, I can't remember if I got a retic count or not. I was going to, but didn't, I don't think.
Hey, Greg,
Anyway, yes.
the other perspective, so I agree 100%. Get him to hepatology. If he says no, and he's like, I'm not going anywhere else, you can treat me or I'm going to die. Treat him with either Harvoni or Epclusa. You don't want to go with anything with a protease inhibitor in it. So basically,
for his liver.
your two choices with a decompensated, he's kind of decompensated. Honestly, that bilirubin and albumin and everything, what's that?
I think
He's so on the edge.
I
Yeah.
think it's either Epclusa with ribo, which he wouldn't be a candidate,
Yeah.
or Epclusa for 24
Yeah,
with him. I would err on the side of Epclusa for 24. Epclusa for 24, I think.
so they're saying longer durations, but those are the only two agents you'd even contemplate. Obviously, you don't even want to go there just for the sake of teaching. It's you don't want to avoid the protease inhibitor ones. Hey, the other thing is I'd get rid of, just until you get him down here to see Hudson's NP, I think the hydrochlorothiazide is not a great idea.
Well, I actually had him hold it anyway because I was afraid his sodium was going to come back 109 or something. I was afraid, and then that was going to exacerbate, make that. Well, I figured this guy would have SIADH. Like I just thought he was going to be a mess, and he is, but not that was the one thing that was normal was his sodium. But he's at least at the moment not taking it. I think most of his hypertension, frankly, is from the alcohol too. So I think if we get him off the alcohol, we could at least then do something for him that might be helpful.
There's a saying that says you don't diurese edema in cirrhotics. You diurese ascites.
Yeah.
And you got to be really careful because if you try to diurese ascites or edema, you tend to make them pre-renal hypovolemic and send them into kidney failure.
Yeah.
You have to be very cautious just diuresing the belly, not the legs. Because they'll almost always have some peripheral edema. That's more sodium dependent, like sodium restriction. But Kaylee will probably talk about that when you do your management of decompensated.
I'll do a talk on that because I think that's
different diuretic management, not HCTZ. It's some spironolactone and Lasix.
Yeah.
But
Right.
hard case, man. Let's get him down here.
Yeah. No, he needs to see a specialist.
Greg, her name is Jean Kernel. I don't know how to spell it. I called her Ashley for a long time. Her name's Jean. She looked in.
That sounds like something I do, man.
She's really cool though.
Right in the referral, Ashley.
I know, right?
So there it is.
But yeah, put Jean Kernel, and then William Hudson is the transplant doc that came here, and so either one of them would be awesome for him to see.
Okay.
Thank you.
Thanks, everybody. I really appreciate it.
Great case.
Great case.
Yeah. Hard case.
We'll see you all later.
Guy.
I hope he shows up.
I really hope he shows